I'm Dr. Anthony Kaveh, a Stanford and Harvard-trained anesthesiologist, and as powerful as anesthesia is, there are a lot of things that anesthesia cannot do if you're having surgery. And some of those include your pain after surgery, your nausea after surgery, and that dreaded sore throat that you get from the breathing tube. So I use a couple of extra tips that are technically placebos because I'm actually not giving any extra medications to patients to affect their pain, their nausea, or their sore throat, but it's based on the mind-body connection that is so real even when you're unconscious under anesthesia, like literally on the operating room table, under the effects of anesthesia. Number one, and you can do this anywhere, is to close your eyes and imagine sucking on a really, really sour lemon. Why on earth would I ever ask a patient in the operating room right before they fall asleep, maybe even with the first couple drops of anesthesia in, why would I ask them to pretend like they're sucking on a lemon? Well, turns out, and you can do this by the way, even if you're not in the operating room, that when you think about that sour taste, actually right now I'm feeling it, my parotid glands and the other salivary glands in my mouth are beginning to clench down, and I have a rush of saliva. I actually have to clear my throat here because of how powerful that effect is. And did you know that when you are salivating, you're lubricating the back of your throat, and that certainly appears to reduce the risk of sore throat after surgery. It's why some of us ask our patients to chew gum if they have a history of a bad sore throat. You know, as an integrative medicine specialist, I also like to use herbs and plants when safe, and licorice lozenges are also very helpful for that, but that's a discussion for a different time. I'm talking about placebo, all in your brain placebo, by definition based on the belief that what you're doing is helping your body, because that belief is real. So when patients begin to lubricate their dry mouth, even if they haven't eaten anything for the last 8, 10, 12 hours or drank anything, that increased saliva, which I still have from me thinking of that sour lemon, begins the lubrication process to minimize that dry tissue from becoming a sore throat after. That was number one. And by the way, if you appreciate me coming on live, unscripted for you here in the operating room after a long day of surgery, I'd really appreciate it if you hit that like button, share what you learned with others. Remember that you have more power over your health, and these tips and hacks are just some of the many examples. Please consider joining the Medical Secrets Premium, my exclusive access, or you can join us in our private Zooms where we hang out and I answer your questions individualized and personally. So you can sign up for that, and your support helps me as well. Let's go on to number two, and this is one of my favorites because everyone thinks that I'm messing with patients when I do this. And that is that when the patient is on the operating room table, about to go to sleep, I say, hey, what do you want to eat when you wake up? So everyone, the nurses, the surgeon, the OR techs, they think I'm torturing the patient because patients are hungry and they haven't eaten for hours and hours, and I'm here asking them what they want to eat? Well, when you fall asleep with the thought of eating something, and I want their stomach to be churning when they wake up, so I tell them straight up, whether it's a hamburger, a pea soup, you know, the most common ones I get involve some sort of like light salad or a chicken soup, and that's cool. If it were me, I don't want something big, like a big, I love lentils personally, I want a big bowl of lentils or something, for many reasons, not the least of which for the nausea prevention, but whatever food it is, I want them to fall asleep thinking of that food so that their intestines are literally rolling over themselves, because the opioids that we give in this operating room to patients when they're under anesthesia literally paralyze your gut. We want the gut to come online as fast as possible, because when the gut is paralyzed, it contributes to nausea. And as you know, while we have many medications that are good for nausea, you also know that having uncontrolled nausea after surgery can be worse than the pain of surgery itself. It can be miserable. And I'll tell you, I'm totally prone to nausea after surgery because I get car sick, I get seasick, I can't read a book in the car. So if I can do something that involves the patient's belief in their mind-body connection, I'm going to do it. So I ask them to think about what they're going to eat. Maybe they'll be salivating as well. When they wake up, many patients are less likely to be nauseous. It depends on many factors, don't get me wrong, but there is no medication involved. And if I'm maxing out everything else, I'm putting on the acupressure bands and giving them ondansetron or Zofran, metoclopramide or Reglan, dexamethasone or Decadron, aprepitant, any medication, we throw them all out there. Some patients are still nauseous. And the power of what their last thought is before falling asleep might be that extra little push to help minimize their nausea so they can keep their food in, so that they can get adequate nutrition, so they're not vomiting. It's also dangerous because some surgeries, you don't want to be actively hacking, coughing, or vomiting because that might disrupt the surgery site. There you have it, 2 tricks you can use anytime, especially the one about food, because remember, if you're waking up hungry, you're less likely to be nauseous and hungry at the same time. It's not impossible, it's less likely. And that is all I want you to remember, because you have incredible power over your mind, over your body, more than you've probably ever been told. So as I promised, let's answer a couple of your questions before we sign off for the day. And we'll start with what's shirt number 1 fan? White shirt number 1 fan. My bad. I have surgery in a few weeks. I'm going to ask for something to knock me out before they even wheel me back. You can do that. They might not be able to give you that medication depending on how the hospital works. Just letting you know. But I'm wishing you the best, and I hope everyone here sends you positive vibes for your upcoming surgery. I still have a lot of extra saliva in my mouth from that lemon sucking exercise I mentioned to you. Wow. Tiff says, I am not on any medications, but now I'm fearful surgeons wouldn't knock me out for surgery. I couldn't bear to be awake. Well, Tiff, most full-on surgeries are performed under anesthesia. I don't know which one in particular you're concerned about. If you're comfortable, you can share it here. So many great comments. And hey, Chris, good to see you. And Alexis, as always. All right. I was both hungry and nauseous while pregnant, says Celia. That can absolutely happen. Celia, all I'm saying is that you are less likely to be nauseous in the setting of the opioid-induced nausea or the anesthetic gas-induced nausea. But being pregnant and nauseous still can absolutely happen. I hope that everything went well with your pregnancy. Adele says, opiates cause me to have seizures. Have you heard of that before? Absolutely. It is very, very uncommon, but it has been documented. I'm sorry, Adele, that you had that. I hope that you always tell your surgeons and anesthesiologists about those interactions. One other shout out, if you appreciate me coming on here and you appreciate me answering your questions, remember that on the exclusive live access, you can get access to me a couple times a month in our Zoom chats to directly ask more questions. But I'll try to answer as many questions as I can here. Versed stopped my breathing during a procedure. Is there an alternative? Versed itself does not stop breathing. When mixed with other anesthetics, it might tip you over the edge. So it happens to the Hollywood actors, Heath Ledger being the prime example. Very dangerous when not used in a medical setting. Lauren, very good to see you. And Joe, can you do a video specifically about ML with a Q&A? Newly found in a FAM, have surgery in 3 weeks. ML, please break down the ML acronym for me, Joe. And board, hey doc, if I get surgery, what are the odds the opiates become an addiction post-op, rather not become another tragic statistic? Board, it depends on many factors. It takes about 5 days of opioid use to begin to increase the risk of opioid use disorder. That is why anything we can do to minimize the unnecessary use of excess opioids is to the advantage of the patient because of the short-term side effects, nausea in particular, constipation, and the long-term risks, which include addiction. Nerve blocks, mind-body techniques, tramadol to an extent, acetaminophen or paracetamol, non-steroidal anti-inflammatories, and many other medications that we can use to minimize the use of unnecessary opioids. Sterling goes in for surgery tomorrow. Sterling Hawk, pardon. I'm wishing you the best, Sterling Hawk. I hope others here also send you positive vibes. I'm prone to nausea every day due to my gastroparesis. Do they give different meds for that? Yes, wild child, we give metoclopramide or Reglan. Sometimes we increase the dose, particularly for that, because of the severe risk of aspiration with gastroparesis. I had nausea and a headache from my surgery, says Renee. I hope that you told your anesthesiologist or tell in the future so they give medications to minimize the risk of those. For nausea, I mentioned the medications already. For headache, I like to add magnesium if it's safe, given a patient's kidney function, etc. Linda, you are so welcome. Jennifer says, I'm on methadone maintenance. How do you prepare me for anesthesia? Jennifer, depends on your other medical conditions, but often, if it's a long surgery, we will continue the methadone. IV form of methadone, that is. We monitor your heart to make sure that the QT interval does not significantly prolonged, and it's very safe and very effective because methadone, unlike other opioids, has NMDA receptor antagonism as well. So it's a different additional pain relief as well. Alexis, totally wishing you the best of luck on your chem exam tomorrow, and I hope your bio and calc exams went well. Heidi, thank you so much for reminding everyone. Pauline, so good to see you on here for your first time. Ann Atkinson had an extreme migraine, burning pre-op from anesthesia. How could it be pre-op from anesthesia, Ann? Maybe post-op? Let me know. Maybe we can answer about why that happened. Hababble, thank you for the kind comments, and I'm wishing you the best as you learn more about doctors. Maybe do you want to be a doctor one day, Hababble? Let us know. KL says, experienced awareness during ECT and was paralyzed, couldn't breathe, and it was out. Did the anesthesia realize I woke up? Did the anesthesiologist realize? I don't know, I wasn't there, KL, but sometimes when a patient is paralyzed, it is very difficult to tell, which is why the risk of awareness is higher when paralysis is used, which is, by the way, a reason why unless it's absolutely necessary, I try to not use paralysis because it helps reduce the risk of anesthesia awareness. KL, I hope that you discussed what happened with your doctor because there's a risk of PTSD that must be addressed, especially in the context of having this for ECT. Okay, so many comments. I appreciate your comments and your positive vibes. Once again, hitting that like button and sharing what you've learned to empower others is so powerful and helps support me as well. Board says, you mentioned mind-body techniques. What are those? Some psychosomatic suggestion, those are some of them, Board. Others include some things as simple as meditation or mindfulness, gratitude practice, believe it or not, Tai Chi, yoga. Gosh, the list goes on, but perhaps breathing techniques are some of the most potent and powerful and easily accessible to us, whether you're in the operating room or on your couch at home, or about to give a speech, or about to lead a meeting, go on a roller coaster. Gosh, anytime in life you have access to a powerful vagal connection between your mind and the rest of your body. You need to learn how to harness that and practice harnessing it, and then its potential can be at your disposal. Great question. Isn't there some brainwave checker that we can identify to see if someone is awake? Skater, surfer, snowboarder, good to see you. There are such wave, EKG. Wow, you totally threw me for a tongue twister here. EEG, electroencephalography based algorithms for looking at ratios of alpha and beta wave activity in the brain to see if a patient's awake. Do they work pretty well? Do we use them all the time? No, they're expensive and often they're not necessary in trained physicians who can use the other available techniques. The exceptions are going to be in cases when patients are so sick that their hearts cannot tolerate anesthesia, and they might need to be very light in the anesthesia, because if you give them too much anesthesia, their heart will fail. But because you're on that fine line, you do risk the awareness. You also can't use those monitors, by the way, if you're using medications like ketamine, because that will disrupt the EEG pattern. So it's a tool in the toolbox. It's not a panacea, though. Very good question. James wants to ask me about the risk of infection from knee replacement after bowel surgery. You need to talk to your surgeon about that. You're on the right track, though, about your concern there. Hey, Incognito, awesome username, and so good to see you on your first live. And Renee, or Ursula, thank you for the kind comments. All right, let's do our last two questions. Hey, Darian, good to see you. You're having eye surgery in a few weeks. I'm wishing you the best for your surgery, Darian, and I hope everyone else here also sends you the same positive healing wishes. Yeah, Renee, thank you for the kind comments. I really appreciate that. Board is like, just like those high-stress breathing techniques used under duress to remain calm and operational. Among other things, yes. And Ann Davis agrees. I love it. Just like how Lamaze breathing can be powerful, it can be powerful in other contexts as well, even in men. Troy, if a patient used to be a heavy alcohol user, how many weeks of complete abstinence would it take to reset tolerance and avoid the higher higher anesthesia needs? Troy, the acute effects take about 4 to 6, maybe 8 weeks in terms of bleeding risk, risk of withdrawals after surgery if you're hospitalized, immune system coming back online to minimize the risk of infections. But in my experience, when I've had heavy alcoholics who've been sober for decades, something about the brain still appears to react unusually to anesthesia. I'm not saying it's good or bad, but the effects of long-term alcohol use, especially in the frontal lobes of the brain, might not be immediately reversible. It doesn't mean that people are dysfunctional for their lives, but I don't know if that ever truly returns to normal, because maybe there is some memory built in, maybe there is some frontal lobe dysfunction. I don't know the answer. I don't think anyone does, because it's rather niche to have the opportunity to work with someone who has truly been sober for decades and decades and decades, and actually meaningfully engage with the patient and see how they respond to anesthesia. Our medical system simply is not designed to hone in on such fine details. All I can say is that I am happy, that I am so grateful for those who have found the inner strength to be sober for that long. And for those that are on the path, I'm wishing you the best to sobriety, to minimize the risk of potentially irreversible, long-term damage to your brain. We'll end with one last question. Susan says, PTSD from the recovery room, paralyzed. Gosh, I am wishing you the best in finding a trusted healer, Susan, to work through that, because it is very serious. And can we repeat how to access your other live discussions, says Joe. Well, if you join the Medical Secrets exclusive access, then you will actually get private invites to our Zoom Hangouts, where over video we all talk with each other and answer questions. And then the last question here was Silver Scale about cannabis. Cannabis does have incredibly profound effects under anesthesia, not the least of which is increasing the dose required to keep patients asleep, up to 200% increase, at least when studying propofol use for endoscopies. So just like how, and I gotta say, Troy, someone on here was congratulating someone who had overcome an alcoholic addiction. I love that community spirit here, us supporting each other. But the same goes for cannabis. Cannabis use disorder is not well recognized, not well diagnosed, but can have deleterious consequences. As you know, I'm not anti-marijuana, but I am anti the inappropriate use, especially to make advertising dollars pay off in sending a message that that marijuana or cannabis is completely harmless and without effect on the especially developing brain, body, and mind. So, and the right strain, the right dose, and the right person can be profoundly healing but you have to know what you're doing. With that said, thank you all for your thank you all for your kind comments. Please share what you've learned with others to help empower your friends and loved ones. Until next time, you have more power over your health than you've probably ever been told.